The current best estimate is that about 30 million people have taken LSD. So far as we know, there has not been a single overdose death.
Welcome to Mind, Body, Health, and Politics. I'm your host, Dr. Richard Lewis Miller. The mission of Mind, Body, Health, and Politics is to enhance your physical and emotional well-being and encourage community. I say encourage community because I believe that human beings are basically tribal animals, and we do best when we live in small tribes where we know everyone, if not by name, by face. That's when we cooperate the most, when we collaborate the most, and we have the least difficulty in crime. Today on Mind, Body, Health, and Politics, I'm deeply honored to have with us Dr. Dave Nichols, the most prominent psychedelic scientist, particularly with regard to LSD, in our country and perhaps on the planet. Welcome to Mind, Body, Health, and Politics, David.
Hello.
In the renaissance that it's being referred to of psychedelic science, namely more research is being allowed than perhaps at any time in the last 50 years or more. There's been emphasis on two, what you might call non-classical psychedelics, but which have psychedelic effects, marijuana and ketamine. And marijuana has been legalized either for medicinal or recreational use in more than half the states in the country, and ketamine is a prescription medicine. We are also seeing research going on with psilocybin, and it is allowed for treatment purposes in two states now, Oregon and Colorado, as well as some cities around the country, including Oakland, California. However, we're not hearing much about our problem child, as Hoffer called it. And yet, in my opinion, LSD has the most potential for healing purposes. So tell us what's going on nowadays, up to date, in psychedelic science with LSD. And if you want to opine about why it's not getting much attention, I'd like to hear that as well.
I think there are probably two explanations. The first has to do with just the political environment. When I started doing research with psilocybin, I was on an airplane with a psychiatrist, and I said we were using psilocybin in studies. He said, "Psilocybin, what's that?" I said, "Well, have you ever heard of magic mushrooms?" He said, "Yeah." Well, psilocybin is the active ingredient there. So there was less, I would say, name recognition to begin with. So anybody, if you say psilocybin, you still have some people today that will say, "What's that stuff?" But if you say LSD, almost everyone knows acid, LSD. Oh yeah, acid parties. So there's that political popular thing that LSD has more notoriety. You know, people taking LSD and jumping out of windows like Art Linkletter's daughter supposedly did, things like that. So there's a lot of baggage, I think. More importantly, perhaps, is the length of duration. When you start talking about doing a clinical study, the people that do psilocybin research now, you can bring people in the morning and you can give them psilocybin as a medicine. You can do your therapy, and then they can usually be discharged by the end of the day. You don't have the overnight stay. With LSD, it's much longer acting, 10, 12 hours. So you're really looking at definitely an overnight stay. So in terms of the clinical cost for experimental studies, it adds to the cost. So if you think of a clinical study, you have the cost of the therapist, the physician, someone sitting there, the cost of the clinical facility, renting the clinical facility, a whole bit that goes with typically a clinical facility. So you have 2 days instead of 1 day. I think that's probably a bigger issue. LSD, of course, in terms of its psychological effect, is more profound than something like psilocybin. It hits a lot of different receptors. And I think more people have had, say, what we might call bad trips with LSD than on something like psilocybin. So it's probably a combination of things. Basically, as far as the current research environment, it's probably the duration of action. And I think in general, people are Even some of the clinicians are more afraid to work with LSD than they are with psilocybin.
And is research going on to find an LSD that is shorter acting?
Well, we made some LSD derivatives that were shorter acting. But if you get a shorter acting LSD, you're really talking about something that has the duration of effect of something like psilocybin, 4 to 6 hours. So probably the shorter duration LSD like compounds, they aren't as well studied. We made some in terms of modification of the LSD structure. Most of them ended up being more potent and lasting just as long. There was one that was a little shorter acting, but we don't really know anything about its clinical effects. LSD has been so widely studied and used that we know quite a bit about, its onset, duration of action, its metabolism, a lot of things you'd like to know. So for a medicine to develop a medicine, we really don't have a good starting point for something that's an LSD derivative that's shorter acting.
What do we need to do? We need in order to harvest the potential of this substance.
Well, most of the money that has supported research in psychedelics has been from philanthropists. And I started the Hefter Institute in 1993. And we funded $10 million worth of research, mostly on psilocybin. So you really would have to start the whole process. You'd have to identify a shorter acting LSD analog. Then you'd have to do a lot of the preclinical toxicology, some animal toxicology, and you'd have to find a way to fund that. So I think if you're starting it with an unknown position and you go to a philanthropist and say, we need $5 to $10 million to do some preclinical and get this going, the question is going to be, well, how is this better than LSD? And you don't know if it is until you do the study. It's kind of a catch-22. You need the study to know if it's as good or better, but then the money it would take to do the study is sort of a non-starter.
But if we're in the position that because it lasts so long, that the research is that much more expensive because of the overnight stay, then it really pushes us to have to find a shorter acting. Otherwise, where are we with a substance that might be usable by the uber wealthy if they want to hire a bunch of people to administer it to them, but it won't be a widely spread medicine that way.
From what I've seen in the published literature, the clinicians who have worked with psilocybin basically feel like it gives them the same medical advantages that LSD does. You still have the possibility of transcendental experiences, life reviews, the same kinds of things you get with LSD. It's a shorter acting compound, but basically seems to have all the advantages of a classical psychedelic. Yeah, if you talk about mescaline, that's a classical psychedelic too. And it's widely used by the Native American church as a sacrament, but it also lasts 8 to 10 hours. So I think if you consider that we would call the classical psychedelics, LSD, psilocybin, and mescaline, they all have generally the same kind of psychological impact. And a difference would be mainly the length of action, duration of action.
I thought you mentioned earlier that LSD reaches the largest number of receptors.
It's promiscuous in terms of where it acts. So if we look at something like mescaline or psilocybin, it predominantly activates what's called the serotonin 2A receptor and also the 2C, with the 2B a little bit. LSD does those, it activates those three receptors, but also activates a whole host of other receptors. So from a pharmacological perspective, it does a lot more things. And when you have a drug that does that many things, you may have side effects that are not appreciated until you do a large clinical study. So, and the mushrooms have been used by, the South American Indians for centuries. So they sort of have a history of safety as well.
Is what we're concluding that even though the psilocybin or psilocin may not have as far-reaching potential as LSD because of reaching fewer receptors, it's still a better bang for the buck in terms of developing a medicine that could have widespread practical use? Is that what it comes down to?
Yeah, it's not that it's lack of off-target, let's say off-target receptors, that's not really a problem. With LSD, we don't know, for example, the pharmacological role that off-target receptors play. LSD activates the serotonin 2A receptor, just like psilocybin does, and that's the one that's the main target for all the classical psychedelics. But psilocybin only activates the 2B, serotonin 2B, 2A, 2B, and 2C receptors. And LSD activates those, but about 8 or 10 other receptors. So
Yes.
you really don't know if you need all that because the ability to produce what would be called a peak experience, it also lies in psilocybin, and that's activation of the serotonin 2A receptor.
As a professional who has done self experimentation with myself as a subject of one, N of one, small n, there's a significant difference between high dose LSD and high dose psilocybin in terms of internal effects, and as a clinician, in terms of being able to reach deeper into corners, if you will, of the consciousness, to reach out to submerged or encapsulated material. Does that resonate to you at all?
Yeah, I think you have a point. If we focus on the medicinal use, which would be end of life distress, substance use disorders, OCD, etc., psilocybin has those effects. Now, if you want to talk about, so you may have heard of a guy named Chris Bach. He took 73 high dose LSD sessions, 600 to 800 micrograms. And, he was going very deep. I'm not sure any of that was really therapeutic. He had some philosophical insights. But if we want to focus on what the average person with depression or anxiety or substance use disorder, what's medicinally relevant for them, you don't need 500 or 600 or 700 micrograms to go to those, beyond, exploration of outer space, if you will.
I interviewed Chris Bosch on this program, and my opinion is that he did not take high dose, he took mega high
Yeah,
dose.
well,
And so he jumped past the areas where, as a clinician, I would do self psychotherapeutic work. He went right into the cosmos every single time. And that's why I believe, as you know as well, that he is somewhat disappointed in the result because he did go into the cosmos and didn't muck around in what you might call the ego level, the places where we've got to do the work in order to affect behavior change and restructure how we are in the world. There's no restructuring when you go right to the cosmos. I've been
yeah,
there. It's wonderful, but you don't get to muck around in the ego. You don't get to look at your fear, your anxiety, your depression.
yeah, that's basically my point. The clinical dose of LSD would be 100 to 200 micrograms, and that's where you're dealing with, you say, the ego, and if you have substance use disorder, looking at why you started using it, why you continue to use it, what it does for you, the whole scheme. So for medicinal purposes, you don't need to go those doses, which is called mega doses. But you can get to that place where you get with 100 or 200 micrograms of LSD. You can get there with 25 to 30 milligrams of psilocybin, in most studies. So I think in terms of, again, focusing on a medicinal use rather than, space exploration use, if you will, psilocybin, is effective. I mean, in Michael Bogenschütz's studies of alcohol use disorder and Matt Johnson's studies of smoking addiction and so forth and the end of life distress, psilocybin has worked fairly effectively, and it's taken people to those dimensions that they need for self-healing.
So you're, as a man who has spent quite a bit of your career investigating LSD, if I'm correct, you're not feeling badly about the emphasis being put on psilocybin. Is that correct? Is that right?
Yeah, I would say that's true. I think as time goes on and we recognize the utility of these compounds, the medical utility, and we start getting government and institutional funding, I think it may be appropriate to look at some LSD analogs and find out what advantages do they have over LSD itself, or disadvantages. I think that time will come, but I think for now, in terms of just getting a public recognition that these things are valuable medicines and represent a breakthrough for psychiatry, I think psilocybin is probably going to do the trick for now.
I think you may have been told that I'm just publishing a book. In fact, it arrived this week called Psychedelic Medicine at the End of Life. And a lot of the emphasis in this book is on psilocybin and its use at the end of life, as you know. My next book is called Psychedelic Medicine Adverse Effects. And that's what I'd like to talk to you about now, because you referenced earlier in our meeting today, you used the word bad trips. And a bad trip is an adverse effect if it's not treated properly. I'd like you to share with us up-to-date current information on adverse effects in psychedelics. And I want to preface it by saying that something that you told me, I think 8 years ago when I interviewed you for my book, Psychedelic Medicine, which you're in. If memory serves, at the time, it was about 2016 or earlier that I interviewed you, you said there'd never been a death from an overdose of LSD. Is my memory serve correct?
That's correct.
Okay. Is that still the case, number one? And number two, I want you to expound on adverse effects from psychedelics in general, please.
The current best estimate is that about 30 million people have taken LSD. So far as we know, there has not been a single overdose death. There have been a couple of deaths related to people having access to huge amounts of LSD, a couple of deaths where they investigated, and based on the LSD content in the person's body, I think in one case, it looked like that person had taken 304, something around 340 milligrams, which is 340,000 micrograms. Those kinds of doses, yeah, they can kill you. But in ordinary doses, anywhere, it's like 500, even 600. Chris Bosch was taking 600, 800 micrograms. You don't normally see a death. So you don't have effects on the physiological systems, your respiratory system, your kidneys, things like that normally would kill you with an overdose. Fentanyl would kill you by paralyzing your respiration. So you don't have those kinds of adverse effects.
No atrial fibrillation, tachycardia.
Not in normal healthy people. I don't know whether anyone has really looked at atrial fibrillation. Wouldn't necessarily kill people.
No.
It would be an adverse effect.
Yes.
Tachycardia wouldn't necessarily kill people. But so most of the studies that we have data for, we have not monitored those things, and those haven't been reported. But no one has died, as far as we know, from the direct effects of LSD.
Now let's get on to adverse effects in general, psychedelic medicine. Take them one at a time for us.
Yeah, the main adverse effects are psychological. An extreme paranoid, a psychotic reaction, the belief that one is insane and can't recover their normal mentation.
I've been there.
Yeah, that someone is out to get them, and they become, very fearful of that. I know of two cases related to LSD. One fella was telling me the story when he was 15 or 16. He and two other people hiked up to the top of a very tall cliff in California. And once they got up there, they took fairly large doses of LSD. And then at some point, one of the companions got very paranoid and said, "You guys brought me up here to kill me, and you're not going to do that." And he became very frightened. I think he had a knife, and they said they spent the whole time up there in deathly fear of being attacked by this guy, because they couldn't get down because they had to climb up this rock cliff to get there. The same kind of a situation happened with another fellow when I was a graduate student. He was telling me the story. He and two other fellows decided to take a large dose of LSD, and while they were sitting there, the third person, he described it as kind of weird, and went to the kitchen and came back and had a knife and sat down and put the knife behind his back. And the other two are thinking, what's this guy up to? Like, he's got a knife and he's acting fairly strange. So these kinds of psychological situations can precipitate an attack or extreme paranoia. Those are the most common.
Both of those examples that you gave, David, are in the area that I call recreational use.
Right.
That was not a medicinal use of
No,
LSD.
no. With recreational use, you can see those things where you don't have the proper set and setting, and you know what set and setting are. But under use where it's been monitored, for example, they've done studies of LSD metabolism, for example, where they give people 100 to 200 micrograms. These studies were done in Switzerland, and then they take blood samples at various times and monitor for looking for the metabolism of LSD and LSD metabolites. And under those situations, they're in a clinical laboratory. They've got professional people there. They trust the people. So when you have that kind of a proper set and setting, you don't typically have those types of adverse effects.
Yes. From my perspective as a clinician, a bad trip means the person is experiencing some form of fear or anxiety.
Right.
And that is meat for a therapist. So that's a good thing that can happen, because with proper treatment by the guide or therapist, they can learn how to conquer the fear and anxiety when it comes up. So then they will have a tool that they can use in daily life for dealing with fear and anxiety in daily life. So in that sense, there really is no such thing as a bad trip unless something happens that even gets out of control of the therapist, right?
Yeah. And that would be in a recreational setting. In a therapeutic setting, if you had, say, something presents as some fearful object, some satanic demon or whatever, the therapist would probably tell you to stare, look at this closely. What is this demon? Why is he there, he or she there? What are they trying to do? What? And so it may actually have its origin, for example, in a childhood trauma that the person has completely repressed. So what you're saying is true. You could use that as a wedge to go back and find out where this is coming from, because typically they may have that some level of anxiety in everyday life, but it's been repressed. They don't remember whatever this childhood trauma was, abuse by a parent, step parent, whatever. So yes, in that kind of situation, it could be an important tool to uncover what is some of the pathology that this person's been living with.
Now, getting back to your two interesting examples of paranoia during high level LSD use in a recreational setting, what can you tell us about the inner mechanism that's triggering what we call paranoia, a fear that something is going to do something harmful to us?
Well, you probably have activated something like the amygdala, which is sort of called the fear area of the brain. If you electrically stimulate the amygdala, you can produce intense kind of irrational fear. So there are receptors in the amygdala that respond to LSD, and so it could well be that's an exaggerated response to the LSD effect in the amygdala, for example. So physiologically, any kind of paranoia or fear could be related to an activation of the amygdala.
Now, I imagine you've also heard, as I have, of people experiencing a similar kind of paranoia from marijuana. Now, would you say that that's also amygdala related, that something's getting triggered?
Yeah, and I couldn't tell you the sort of physiological chain of events that would cause it. But if we assume that the same areas of the brain are responsible for producing these fear responses, regardless of the drug, it must be the same area of the brain. So marijuana activates cannabinoid receptors. And so presumably, and my understanding is when people have a paranoid reaction to marijuana, it's often when they have encountered an unexpectedly potent marijuana,
Yes.
typically low potency, but people
Yes.
smoke really high potency and then they get frightened.
Yes.
Yeah. And I would say probably the brain mechanism is probably very, very similar, if not identical. The fear response in the brain, where the part of the brain that does that is not going to change depending on the drug. So, but there's going to be a different mechanism. The cannabinoid receptors are doing something that's causing activation, say in the amygdala.
What's your opinion on the following theory that I have formulated regarding that with marijuana? Namely, there's an increase in blood pressure and heart rate in the early stage of high potency marijuana. You know that.
Yeah.
And in our culture, we are taught to look around us when there's something where we feel fear inside or anxiety. We're not taught to close our eyes and look within. We're taught more to look outside. Is something coming at us? Is somebody going to do something? Is there a flying object or fire, right? And so when the people take this high potency marijuana and they get a sudden spurt of heart rate going up, along with blood pressure at the same time, they can feel internally this lack of equilibrium. All of a sudden, they're off their homeostasis. There's a lot of activity, blood pressure and heart rate. And so, in line with their training culturally, they start looking around for what might be causing that. And looking around for something causing a bad feeling can be labeled paranoia,
Yeah.
right?
Yeah. I think that's true. And the other thing is when people have a fear response to a real fear, you have an increase in heart rate and increase in blood pressure. So it's a
Yes.
physiological response to something. Normally, if you were being attacked, you would have that kind of response. So you take this high potency marijuana, that response happens. And so it triggers the same kind of mechanism, like what's going on, what's causing this. And that would
Yes.
produce the same fear, paranoia. Yeah.
Yeah, that's my theory. And so
Yeah.
they start when they get scared that something bad's going to happen to them outside.
Right. Right.
And when I've been in that situation, as you do recall that I've treated chemically dependent people, what I've taught them to do is to look inside, and by looking inside and regulating their breathing, they feel better. But that isn't a kind of soul-searching response. That's more of dealing with a physiological response. That's not the same as when all of a sudden on LSD, somebody sees something which they haven't seen in 50 years because it's been suppressed into some recessed corner of consciousness, and all of a sudden the LSD opens the door and out pops
Exactly.
sexual abuse or some terrible event, right?
Yeah. The kind of fear that they suffered as a child, if that's been repressed and then under LSD it's brought out, it manifests as a fear that's appropriate to their age. So it may have scared the hell out of them when they were 4 years old being abused. And then when they're 30 or 40, they take it, that fear comes back, but it's magnified to be proportionate to their level of development. So it seems much more dangerous rather than seeing, oh, that's what happened. And so in the therapy where you would use LSD and that would happen, you'd focus on that person and say, where is this fear coming from?
Yeah.
And ideally, you'd take them back, regress them back to where that happened as a young child and say, this is where it's coming from. And then that fear would dissolve in their adult life, a PTSD type treatment.
Yeah. Anything else you want to add on adverse effects before we move on to another topic?
No, I think we've covered enough of that. Yeah.
Do you want to opine on the recent FDA decision regarding MDMA?
I, like many people, are very disappointed. In my opinion, it was a political decision. I've asked a number of people if they've seen the entire report from FDA. No one has talked about it to me. I think that the advisory committee that they selected was not appropriately educated about the effects of these drugs. They took one example of this example of the fellow in Canada that abused a patient under MDMA, one of his patients. They took that as like, oh, this has a high potential for abuse. Also,
Are you saying that they generalized from that transgressor to saying there's something about this medicine that lends itself to the treatment provider transgressing?
Well, I mean, why else would they bring it up as an example? One
I don't.
example.
I
Yeah,
don't know, but for me, that's borderline non sequitur
yeah.
because you have a rotten apple in the barrel. That
You know,
doesn't mean that apples are bad.
right, right. And then they had one person on the advisory committee who said, we already have plenty of treatments for PTSD. We don't need this other one. And that's just simply nonsense because
That's nonsense.
I've talked to many therapists. They say, I've treated people with PTSD for years with SSRIs and SNRIs and, 10, 12 years and nothing, you can alleviate the symptoms, but you can't cure them. And then we have a session with MDMA or two sessions. And all of a sudden, after 15 or 20 years of PTSD, it's gone. And
Yes.
so this guy was completely nuts. And I think that psychiatry is probably the most conservative branch of medicine. And I think they're very resistant to change. And there's all this crap about exaggerated dangers of psychedelics and MDMA. And I think that the advisory committee I think it was political. And I've talked to many people many therapists who you actually used it and said, we think it's political. It's a political decision. And that's my opinion. It's very unfortunate because there are so many people with PTSD. We have daily suicides of veterans who have PTSD. Every day, at least one veteran is killing him or herself. And, this is terrible that they've said, no, you can't move forward with this because of some technical crapola that they brought up. So I think it's political myself.
I was given MDMA in my therapist's office while it was still legal in the early 1980s. And the first time I took it, I recognized immediately, as did every therapist I know who took it, recognized immediately that this is going to be a tremendous medicine, particularly for couples, because it reduces defenses and it opens the heart for empathy and careful listening. And so often couples don't listen to each other. They're just both monologuing. And I recognized it then. And that's after that, it was a few years later that I met you and I met Rick at 85 in Esalen. It's 39 years later from when MDMA was taken off the market and scheduled. And we're still fighting the same fight, as you point out, mostly for political reasons. Now, there was one thing in the study that I want to ask you about. The study that it was headed up, the research study, by a company called Lycos,
Yeah.
which is an offshoot of MAPS. I read that 40% of the subjects had experienced MDMA prior to the research. Did you read that?
I haven't seen that statistic. I'd be surprised if it was that high, but just taking it by itself, this is one of the fears. I talked to someone actually just at a meeting a couple of days ago. Their fear is this guy who's taken over Lycos is of the opinion that we don't really need the psychotherapy. We could just give them MDMA and they're going to be healed. And there's a great fear that they're going to screw this up by doing the third clinical trial just by giving people MDMA with no therapy, and it won't work. And it'll destroy it because they don't understand it has to be coupled with therapy.
David, you and I know that would be a travesty.
Oh, it would be
Psychedelic medicines are not meant to be used by the patient alone.
No.
That would be almost criminal.
But this guy who's taken over Lycos, I mean, there are implications that he might do that the psychiatric community says, well, it's like an SSRI, we give it to people and that's all they need. And they don't understand. There's a lack of awareness of how these substances actually work. And if they do that, it'll ruin it. So we're all hoping that they don't actually do that. But there's been some rumblings that this guy might think that's the way to do it. And obviously, you and I both know that's not the way that MDMA works or any psychedelic therapy.
Anybody who knows anything about psychedelics, I mean, this is almost a given. Anybody who knows anything knows that you want a guide if you're going to do psychotherapy, because even Freud said you can't do psychotherapy on yourself. And basically, that's what you'd be doing if you took that pill alone in a room. It almost turns the experience from a medicinal experience into a recreational one.
Yeah. And if that worked, all the people that have taken MDMA at raves, they would all be in perfect mental health now, wouldn't they?
Given that I've taken it over 100 times, I would be a guru by now,
Yeah.
or living in a mountain with a loincloth.
So I hope that doesn't happen. The problem with that FDA advisory committee is they really didn't have anybody on there. They were all sort of mainstream psychiatrists associated with the drug industry where you just take a pill and it works. They just don't appreciate that. I've had people ask me this idea that psychedelics can be developed that don't produce a psychedelic effect. That's a big thrust now. You hear non-psychedelic psychedelics, and there's a major company that's trying to develop those because there's this impression that we don't want people to have this. We don't want people to experience this. And of
Right.
course, if you talk to someone who's actually had the experience and you say, well, would you rather have just taken the pill and not had this happen at all? And they go, well, no, that was one of the most powerful experiences, most important experiences of my life. But there's this impression, and people said, well, what do you think about that? I said, for major depressive disorder, I think it's perfectly fine if you develop a pill that you can give somebody and it cures their depression. That's fine. But I said, for somebody who's in existential distress, who's dying, or who's got substance use disorders, there's a cognitive component to that. People, and I've seen videos of people that were in some of the clinical trials with psilocybin who were dying patients. They got a whole perspective on their life. They saw they'd become estranged from siblings and parents. They wanted to reconnect. It gave them an increased quality of life at the end of life. The same thing, the first study that Michael Bogenschutz did with psilocybin-assisted therapy and alcoholism, he had a woman come in and I saw her video. She was one of the subjects, and she had tried to get her husband into the study. And he didn't want to do it. So she came in, she said, I want to get my husband in. And so Michael Bogenschutz said, well, what do you drink? Do you drink? And she said, yeah. She said, maybe you should fill out the questionnaire. She filled out the questionnaire and he said, you qualify for the study. Really? She got in the study. So I saw the video of her afterwards. And she said, completely changed my life. She had a couple little kids. She was a Hispanic woman. She'd come home at the end of the day, exhausted and tired. The kids would want to come and get some attention from mom, and she'd kind of push them away, sit down and have some drinks, get intoxicated. And that was her life. And she said, when I took the MDMA, and this was psilocybin, she said, I took the psilocybin, I realized I was cheating my kids. And I stopped drinking because now I come home at the end of the day. I call my kids to me. They come and I hug them and I'd say, tell me about your day. Complete change in behavior. That won't happen with a pill. It happens with the cognitive insight you get with the psychedelic that shows you this is how you've been failing. This is a way you can improve. If they don't understand the way psychedelics work, they're not going to appreciate that at all.
No, they're not going to. It's been a long time, been a long haul, David, that we're going through this. Over 50 years.
I gave a talk. I went out to Asheville. We were out there yesterday, and there's a place called the Pearl Institute that Raymond Turpin runs. He uses ketamine right now, but it was a group of people that support his not-for-profit institute. There were 290 people in the audience. There was a couple of veterans that had had PTSD that I got up and said, this therapy, I don't have it anymore. This is amazing stuff. And I got up and I said, you have to be patient. I said, I started this field in 1969. And I said, we're not where we should be yet. But I said, don't give up. It's going to take patience and persistence. But I said, we are going to get there because this stuff works. So don't give up. I said, I've been doing this my whole life. And, I said, like Martin Luther King, I may not get there with you. I might be gone by then, but we'll get there. And just be patient. And, it's been drug war. The phony drug war started in 1970. And it's just been terrible. What's marijuana in 1937? There was never any real basis for scheduling marijuana. It was Harry Anslinger. He was a drug lawyer and said, Mexican laborers are bringing marijuana across the border from Mexico, giving it to white women and raping and killing them. And that's the basis for scheduling marijuana. And you still see these states today going, well, should we legalize marijuana or not? And marijuana is far less dangerous than alcohol. We don't have any problem selling alcohol, concentrated alcohol, whiskey, liquor, no problem with that. And all the alcoholics and all the DUIs and things, we've got that. No question about that. But marijuana, No, I don't know if we should make that legal or not. Well, let's, maybe medical marijuana. And so it's crazy the way people think about these.
It's because they're being sold misinformation
Yeah.
in the guise of religion or some other kind of morality, and they develop an attitude which is far away from the science. And from those of us who believe in the science, they look like they're living on another planet.
Yeah.
I love your optimism. I'm 85 years old. I think I will now switch to what you said and use Martin Luther's slogan that it may not happen in my time, but it will happen. So thank you for the reminder about the importance of optimism.
I had a woman that asked me, and I brought this up in my talk. A woman asked me, 5, 10 years ago, what do you see as the future of psychedelics? And I said, well, someday, probably long after I'm dead, you'll be having a midlife crisis, and your physician will send you down to the corner to see a shaman/psychiatrist, and he'll give you a session with a psychedelic. You'll get a new perspective on your life, and you'll be good again. And she said, oh my God, do you think you'll be dead by then? I said, probably, but I said, as long as the vector's pointing in the right direction, that'll be a good thing. So I think the vector's pointing in the right direction. We just have to be persistent. And this crowd last night, there were 290 people there that are supporting this institute. Last year, he had many fewer. In the first year, he had many fewer. It's growing, its popularity. People realize this is an important medicine, and we'll eventually get there. But, it's just, you just have to be patient.
When I was at the Psychedelic Science Conference in Denver in June, was it a year ago? I approached 5 police people who were outside the conference center. They were standing there and talking. And there were a bunch of kids out on the lawn there playing guitars and so on. And I introduced myself to the police people, and I said to them, I want you to share your thoughts on what's going on here with all this 12,000 people meeting about psychedelics. How do you all feel about that? And the head of their group, I think it was a captain, I'm not sure what the rank was, looked at me and said, every one of us on the police force has had one of our family members fucked up by Big Pharma. If these people have something better to offer, you sure as hell better believe we're going to listen. And I think that adds to what you're saying about the vector going in the right direction.
Yeah.
They're going to listen. We're all listening, David. We're listening to the science that you've been putting out for all these years, and we're hearing it. And I want to thank you for the enormity of your contribution, your dedication, and your optimism, and for being here today. Thank you.
Yeah. It's been a labor of love.
A labor of love. And thank you all, gentle listeners, for being with us on today's broadcast of Mind, Body, Health, and Politics. I remind you, we come out with a new broadcast every week, and you can go to the archive, which is the handiest way of listening to all the programs, and open source, no fee to you. All of our recordings for the last 20 years are without charge, so dive in, have some fun. Until next time, this is Dr. Richard Lewis Miller reminding you that good health is worth fighting for, and it's essential for life, liberty, and the pursuit of happiness.